So let's begin and let's talk about trochanteric bursitis. Trochanteric bursitis, sometimes referred in the literature to as TB, not tuberculosis, but we're talking here about trochanteric bursitis. Now, trochanteric bursitis describes a chronic pain, a chronic hip pain, which can come and go. It can be intermittent, but it's a definite and chronic pain located at the hip, accompanied by a pathognomonic physical exam sign, which involves tenderness to palpation overlying the lateral aspect of the hip. And you can feel the location of the trochanteric bursitis by reaching down to your own greater trochanters of your hips and just rubbing your fingers over the bony prominence of the greater trochanter. That greater trochanter is lined on all of its surfaces, anterior, posterior, and superior, with primary and secondary bursae, that collectively which are known as the trochanteric bursae. And so trochanteric bursitis can refer to inflammation, aggravation, irritation of any one or multiple of those bursae. Now, trochanteric bursitis is known as the great masquerader because it can be frequently mistaken for other conditions, because there are other conditions that can produce pain located in the general region of the hip. Now, another mnemonic, not TB for trochanteric bursitis, but GTPS is the name given to the constellation of syndromes known as greater trochanteric pain syndromes. GTPS. Now, GTPS refers to pain in the lateral hip, the buttock, or the lateral thigh, all of which may be associated with either tendinitis, muscle tears, trigger points, disorders of the iliotibial band, and other generalized and localized pathology in the surrounding tissues in and around the hip joint, all of which have in common that they can produce pain in and around the greater trochanter. For that reason, this constellation of syndromes is referred to as GTPS, greater trochanteric pain syndrome. So GTPS is a regional pain syndrome, the region being the region of the hip joint, that often mimics pain generated from other sources, including but not limited to myofascial pain, degenerative joint disease, and spinal pathology. So by referring pain from the spine, we see that pain can be both localized, and pain can even be from distant sources, such as the lumbar spine. Now, some of these other conditions that are associated with GTPS and that can refer pain to the region of the greater trochanter include some of the following conditions. Number one, ipsilateral and even contralateral hip joint arthritis and degenerative change of the hip joint. Number two, lumbar spine degenerative osteoarthritis. Number three, lumbar spine degenerative disc disease. Number four, chronic mechanical low back pain can refer pain to the region of the greater trochanter, greater trochanters. Rheumatoid arthritis, leg length discrepancy, post-surgical lumbar disc disease, radiculopathy, a common presenting condition in the industrial setting. Lumbar spine radiculopathy can refer pain to the greater trochanters. Obesity, fibromyalgia, iliotibial band syndrome, also known as snapping hip syndrome. Hip replacement can cause greater trochanteric pain syndrome, lower limb amputation, and then mechanical faults and failures of the lower extremity. For example, flat foot, pes planus, and other mechanical faults of the lower extremity all can refer pain to the generalized region of the hip and can be mistaken for trochanteric bursitis. Now, a couple facts about trochanteric bursitis. Trochanteric bursitis has a higher reported incidence in women. It has a higher reported incidence in those patients, or we'll call them examinees, with leg length discrepancies. Now, leg length discrepancies are one of the physical examination investigations that we perform with regards to our lower extremity exam. In fact, leg length discrepancy does qualify for permanent impairment, and so it is a part of the routine physical examination of the lower extremity. So when you have an examinee with a bona fide and measurable leg length discrepancy, do not be surprised if that person reports pain in the generalized region of the greater trochanter and the hip joint. Also, trochanteric bursitis has a higher incidence in those examinees who report concomitant lower back pain, also those that report knee pain. And these two factors, the low back pain and the association with knee pain, suggest that altered lower limb biomechanics and abnormal force vectors across the hip may predispose patients to greater trochanteric pain syndrome. Now, signs and symptoms associated with GTPS include pain to palpation over the area of the lateral hip. And as we're going to see, there are not a whole lot of hardcore physical examination maneuvers and tests that we can rely on for diagnosing GTPS, but one of the consistent findings associated with GTPS is pain to palpation over the area of the lateral hip, specifically in the region of the greater trochanter. Some examinees will report that the pain radiates down the lateral thigh, sometimes even as low as the knee, and even some cases to the lateral shin, the upper and lateral shin region. Examinees will have tenderness in the area over the greater trochanter, sometimes associated with a jump sign to direct palpation pressure. With passive examination movements, examinees may report pain with passive hip rotation, passive hip abduction, passive hip adduction, or any maneuvers that stretch tissues over inflamed bursa at the greater trochanter can reproduce pain. Similarly, on active motions, some examinees will report pain on manual muscle testing around the hip, specifically the test motions of resisted hip abduction and resisted hip external rotation, both of which have as their mechanism of irritation being due to activation of the gluteus medius muscle. The gluteus medius muscle is a combined hip abductor and secondarily a hip external rotator. So patients may report, or examinees may report, pain with those two resisted motions. And then also, because of the pain in the hip joint associated with passive movements at the hip joint, Patrick's Faber test may have some value in localizing pain to the greater trochanter as well. And we'll have a demonstration of Patrick's Faber test in a video coming up here shortly. and I'll demonstrate how Patrick's Faber test can reproduce pain associated with greater trochanteric pain syndrome. Okay, so let's talk about the anatomy of the hip and the greater trochanter and the bursa that surround the hip, so that we can understand what's actually going on and what's involved in producing the condition of GTPS. Now, recall that the hip socket is a synovial joint, a diarthrodial synovial joint. And like other synovial joints throughout the body, synovial joints, all synovial joints in the body have some consistent features and some consistent anatomic structures. So let's review those. Number one, all synovial joints have articular cartilage. Now, articular cartilage lines the articulating surfaces of the bones that make up the joint, and in the hip socket, the articular cartilage lines the head of the femur bone, and then also lines the interior surface of the acetabulum. And articular cartilage is hyaline cartilage, and it extends to the periphery of the articulating surfaces of both bones that make up the joint in question. And here we're talking about the hip joint. Now, the articular cartilages are surrounded by the articular capsule. And the articular capsule is an interesting structure. The articular capsule is sort of the dividing line between the interior of the joint and the exterior of the joint. In the interior of the joint, the inside of the articular cartilage and the interior of the articular capsule are bathed in synovial fluid, as that synovial fluid lubricates and lines the interior cavity of the joint, known as the synovial cavity. So we have articular cartilage, we have a synovial cavity, we have an articular capsule that surrounds the synovial cavity, and then we have the synovial cavity being bathed in synovial fluid. And the synovial fluid is secreted by cells that line the interior of the synovial cavity. And these are secretory cells. They're simple cuboidal epithelial cells whose purpose is to secrete this lubricating joint synovial fluid. And then the exterior surface of this synovial membrane is lined by fibrous tissue, and the fibrous tissue becomes adherent and continuous with the articular capsule. So quite an interesting structure, the synovial membrane. Okay, and then on the outside of the articular capsule, all synovial joints have, to greater or lesser degree, various different types and configurations of reinforcing ligaments. Now, reinforcing ligaments come in three different varieties. We have extra-articular ligaments, such as the medial and lateral collateral ligaments. Those are extra-articular ligaments. We have intra-articular ligaments, and those are ligaments that actually pierce the synovial cavity, or pierce the articular capsule and enter the synovial cavity, and are classified as intra-articular ligaments. Examples of intra-articular ligaments would be like the anterior and posterior cruciate ligaments. And then in addition to those, we have some ligaments that are not true ligaments in and of themselves. However, they are more just thickenings of the articular capsule, localized thickenings or localized bands found within the articular capsule. And these are particularly common in the highly immobile joints, such as the shoulder. So in the shoulder, we have three groups of ligaments that we refer to as the glenohumeral ligaments. We have the superior, the middle, and the inferior glenohumeral ligaments. And the glenohumeral ligaments are really nothing more than localized thickenings of the articular capsule. And what these are localized accumulations of collagenous, dense, regular connective tissue that becomes stretched and taut as the joint goes through range of motion, and that provides stability to the joint. So for those of you that have the PowerPoint presentation, I have here a diagram of a typical synovial joint, and this could be the knee, this could be the shoulder, this could be the hip. This is a representative synovial joint, and you'll notice all those structures that we talked about. Number one is that the articular surfaces of the bones are lined in blue hyaline cartilage, and both ends of the bones would be lined with hyaline cartilage. And in the hip, the hyaline cartilage lines the end of the femur bone and the inner surface of the acetabulum. And you'll notice that the hyaline cartilage extends about as far as the articulating surface of the bone that makes up the joint. And thereafter, the articular cartilage becomes continuous with the synovial membrane, diagrammed here in this diagram as this green membrane structure. Now, these synovial membranes are two-layered structures. The inner, or the joint-oriented layer, is a secretory layer. It's lined with simple cuboidal epithelium, whose job it is to secrete this specialized fluid that we call synovial fluid. And then the outer layer of the synovial membrane is fibrous tissue that is virtually continuous and indistinguishable from the fibrous capsule, indicated here in purple. And so the synovial cavity is lined with synovial fluid, and it's the synovial membrane and the articular capsule that separate the interior of the joint from the exterior of the joint. And then, at least in this diagram, we have some external ligaments here. We would refer to those as extra-articular supporting ligaments. Now, in addition to those structures, synovial joints also have some other structures associated with them, the purpose of which is to reduce friction. Now, in the shoulder and in the hands and in the feet, we have what are known as tendon sheaths that surround tendons of especially mobile tendons that cross the joint. So a tendon sheath is a flattened fibrous sac that surrounds tendons, and it's common in areas where there's high friction loads on tendons that cross in the joint. So the biceps tendon up at the shoulder, for example, has a tendon sheath, and then they're also common in the hands and feet. Now, if a tendon sheath is a flattened fibrous sac that surrounds tendons, what do we have in areas that are also subject to a lot of mobility, a lot of tissue mobility, and a lot of friction, but that aren't associated with muscles and tendons? Well, we call those bursae, and bursae are a lot like tendon sheaths in that bursae are also flattened fibrous sacs. They are lined with synovial membranes, and they contain synovial fluid. And bursae are very similar, if not histologically identical, to the synovial membrane of a diarthrodial joint. Now, the inner layer of the bursae is a secretory layer, and the outer layer is a fibrous connective tissue layer that becomes adherent and continuous with localized structures. So there's an interior to a bursa, and there's an exterior to a bursa, and the interior of the bursa contains synovial fluid, and it's just like joint synovial fluid. Now, bursae are common where ligaments, muscles, skin, bones, and tendons rub together. And the purpose of bursae is to reduce friction. And interesting is that around the knee there are many bursae, because the hip and the knee are areas where there are high mobility and high capacity for tissue frictions. So for those of you that have the PowerPoint presentation, and if you don't, you have this handout in your notes. I have a diagram here that shows both of these friction reducing structures in the shoulder. So here, underneath the acromion process of the shoulder, is the subacromial bursa, and then here, surrounding the long head of the biceps tendon, is a tendon sheath. And you'll notice they have both the same histologic structure, and that is that they're composed of an outer fibrous layer and an inner secretory layer, and the inner secretory layer secretes the synovial fluid. Now, many times these bursae are located around joints, because joints are areas where there are high degrees of friction generated. And generally, and in most cases, the bursae are continuous with the synovial cavity of the joint. Now, in a non-pathologic joint, meaning in a normal joint, the communication or the connection between the bursa and the synovial cavity of the joint is only a potential communication, meaning that the communication channel is usually closed in the normal circumstance. But in the case of pathology, whether that be due to pathology of the synovial joint itself, or pathology with the bursa, or some combination thereof, this potential communicating space opens up, and there is exchange of fluid from one compartment into the other. And these communications can many times be picked up on MRI. In the case of a pathology of either the synovial joint or a pathology of the bursa, we will see fluid communication passing from one synovial cavity to another. And that is common in both the shoulder and in the hip. Now, in the hip, there's several named bursae that we'll be talking about and that are involved with trochanteric bursitis. And so let's go over the anatomy of the bursae in and around the hip joint. Now, centered directly over the greater trochanter is a group of 3 different bursae. These are collectively known as the subgluteus maximus bursae, and I have a diagram of these to show you here in just a minute. Now, slightly below the subgluteus maximus bursae and slightly more lateral to the greater trochanter, so you can feel this and palpate this on yourself. Just put your fingertips on the greater trochanter, drop slightly inferior, and then slightly posterolateral. We have the gluteal femoral bursa, and this is a large bursa of which there's only one. Now, moving your fingers back to the greater trochanter, if you move slightly superior and slightly anterior, we then have the subgluteus medius bursa. Then if you move your fingers posterior and then slightly superior to the greater trochanter, we have the piriformis bursa. And then back to the greater trochanter, if you move your fingertips slightly anterior and then slightly inferior, we then also have the subgluteus medius bursa. And any one of these or any combination of these can be involved with greater trochanteric pain syndrome. So here, those of you that have the PowerPoint presentation, I have a diagram here that shows each of these bursa, and I'll point them out to you. So here we have our greater trochanter here. This is a diagram of the right hip. So we have the greater trochanter here, and you'll notice here that here is the superficial subgluteus maximus bursa directly over the widest part, the most lateral part of the greater trochanter. And we have a superficial bursa, we have a deep bursa just below that, and then we have a secondary subgluteus maximus bursa slightly anterior, directly in a line inferior to the greater trochanter. So those make up the three bursa and subbursa of the subgluteus maximus. Then we have the gluteofemoral bursa located a little bit inferior and slightly posterior, and this one here wraps around posteriorly, although you can't see it here from this diagram. It's just a little piece of it peeking around on the lateral aspect of the upper femur here. Then superiorly we have the subgluteus medius bursa that reduces friction between the greater trochanter and the tendon of the gluteus medius muscle. Not shown in this diagram is the piriformis bursa, because the piriformis bursa is more posterior. And then finally we have the subgluteus minimus bursa that reduces friction between the greater trochanter and the tendon of the gluteus minimus muscle. Okay, so signs and symptoms, again, associated with greater trochanteric pain syndrome include pain directly over the area of the lateral hip, and examinees will tell you that they have pain on their hip when they lay on that side. In other words, they say that they cannot lie on that side. So that's something that you'll be paying attention for, is a report that they cannot lie on that side. That would be an indication of direct pinpoint and palpatory pressure to the bursae in and around the greater trochanter. They'll report pain that radiates down the lateral thigh. The pain, don't be surprised if it goes to the knee and even slightly below the knee. This is a non-dermatomal distribution of pain. They'll report local tenderness over the area of the greater trochanter, and on physical exam, a positive objective finding would be a positive jump sign that would substantiate a subjective complaint of pain to have a positive objective finding such as a jump sign. They'll also report pain with various passive and active motions in and around the hip joint, especially those motions that stretch the tendons of the gluteus medius, the gluteus minimus, and even the gluteus maximus in the case of the gluteofemoral bursa. Now, some of the criteria for the diagnosis of trochanteric bursitis, and this is from Lippincot's Primary Care Orthopedics, 2nd edition. As I said earlier, there are not a lot of definitive physical examination maneuvers for diagnosing trochanteric bursitis. But we do have several pathognomonic signs and several pathognomonic symptoms that would be suggestive of greater trochanteric pain syndrome, including some of the following criteria. So, number one is the presence of lateral hip pain associated with distinct and reproducible tenderness about the greater trochanter. And this tenderness most likely and generally would be associated with a jump sign to direct palpation pressure. Pain at the extreme of hip joint rotation, abduction, or adduction, especially with a positive Patrick's-Faber test. And remember that Patrick's-Faber test includes flexion, abduction, external rotation, and extension, all of which would tense and tighten musculotendinous structures crossing the greater trochanter. Pain on hip abduction against resistance will be your primary manual muscle test to tense the gluteus medius muscle across the greater trochanter. And then be aware for confounding distributions of pain, particularly pain that radiates down the lateral aspect of the thigh. This is the so-called pseudo-radiculopathy. It's in a non-dermatomal distribution of pain. Can sometimes mimic pain associated with entrapment of the lateral femoral cutaneous nerve, although a distinction between the two is that while lateral femoral cutaneous nerve entrapment can cause symptoms in the lateral and posterolateral aspect of the thigh, typically with entrapment of the lateral femoral cutaneous nerve, we will have less symptoms of pain and more symptoms of paresthesiae, such as numbness, tingling, prickling, burning, etc. Whereas with trochanteric bursitis, the examinee is going to more commonly report pain, just plain pain, and won't report any of the paresthesiae. So that's a couple of clinical factors that distinguish those two conditions. Okay, so continuing along on signs and symptoms, let's review. Probably most reproducible is extreme sensitivity, usually found near the gluteus medius insertion site on the greater trochanter. That would be physical examination finding for inflammation, irritation, or pathology of the subgluteus medius bursae. Symptoms are aggravated and exacerbated by specific hip maneuvers, such as extreme hip abduction and external rotation. And then interestingly, and I promised you this earlier, the AMA guides on table 1733, they provide for permanent impairment of trochanteric bursitis. However, they require that there be positive, definitive, objective evidence that the greater trochanteric bursitis impairs normal gait. In other words, you can have trochanteric bursitis, you can have extreme sensitivity, you can have pain, lateral hip pain, with extremes of hip abduction, hip external rotation, and you can have all these positive physical exam findings, and you can have all the signs and symptoms suggestive of trochanteric bursitis. However, if those symptoms and those signs do not impair gait, then the AMA guides do not provide for permanent impairment due to chronic lateral hip pain. So let's think about this. With chronic lateral hip pain bad enough to impair gait, what kind of gait disturbance findings could you find? Well, is it possible that chronic, intermittent trochanteric bursitis due to, for example, gluteus medius tendinitis, is it possible that that gluteus medius muscle could be weak? Is it possible that that gluteus medius muscle could contribute to a Trendelenburg gait due to weakness of that gluteus medius? Maybe this is something that would be manifest only after extended or unusual exertion of the gluteus medius muscle. For example, as described in the AMA guides, with walking long distances, with walking up hills, with walking up grades and elevations. This is the type of thing, the type of activity that could be sufficiently vigorous to exacerbate that gluteus medius muscle and contribute to an Trendelenburg gait. In that case, the trochanteric bursitis would qualify for permanent impairment. Is it possible that the trochanteric bursitis could contribute to an antalgic gait? Maybe not a Trendelenburg gait that involves weakness of the gluteus medius muscle, but simply pain with stepping down and bearing weight and contracting either the gluteus maximus, the gluteus minimus, the gluteus medius muscle across these various bursae could be sufficient to cause an inhibitory, painful withdrawal reflex, thereby shortening the stance phase and contributing to gait disturbance due to antalgic gait, as we described earlier. Simply a maneuvering of the examinee and a change in the gait in order to prevent further pain in the hip region. So those types of findings you would expect to find, and those are positive objective examination findings that would substantiate, number one, your diagnosis for trochanteric bursitis, and then number two, would substantiate any permanent impairment rating that you provide on the basis of a gait disturbance associated with the greater trochanteric bursitis. Okay, so now we're going to go into a couple of examination maneuvers for greater trochanteric bursitis, and I'll demonstrate some of the maneuvers that you can incorporate into your physical examination of the hip if you suspect that there may be one or more of the greater trochanteric pain syndromes present. And I'll demonstrate some of these physical examination maneuvers, and then when we continue, we will then get down into the knee and talk about some of the knee instability syndromes. Okay, so let's go on now to some videos on physical examination maneuvers for trochanteric bursitis.